Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who actually wears hearing aids. However, over the course of the last couple of months, they've been finding that inserting the hearing aid is quite painful for them. And in particular the right ear. And we can see this patient's got really dry, crusted earwax and dead skin, and it's fully occluding. And as they're inserting the hearing aid, it's pushing this wax deeper into the ear and up against the eardrum, and that's the root cause of their otalgia. So otalgia is a medical name given for an earache. And in addition, they've noticed that the hearing aid has been whistling, what we call acoustic feedback. So acoustic feedback whistling occurs when amplified sound is pumped into the ear canal. If it hits the wax and reflects back out of the ear, that amplified sound re-enters the hearing aid microphone. So the hearing aid is then re-amplifying and processing that same sound for the second time. And then again, the sound gets amplified back in the ear and it gets reflected back out, and the hearing aid once again re-amplifies that sound. And you can see where we're going with this. We get an acoustic feedback loop, and that causes the hearing aid to squeal and whistling. And people besides you can also hear it. So it's very... it's not a very nice thing to experience. Sometimes the patient themselves, due to their hearing loss, can't actually hear the feedback, and it's their friends and family besides them that are noticing it and who are getting annoyed by it and frustrated by it. So you can see we've removed the bulk of this really dry wax skin. Now the patient has also got eczema. They've got eczema in other parts of the body as well, so it's not just exclusively in the ear. So we called this dry skin in the ear, it is due to eczema. We call it the umbrella term when it's in the ear, it's otitis externa. They have got some medication, prescribed sprays for the ear, which they use as and when necessary. And importantly, they do avoid water entering the ear. And you'll see in a moment, this dry skin, it's like a dead layer that's coating the whole ear canal. I'm going to spend a bit of time in a moment peeling all this away. So it's going to reveal a fresher layer of skin underneath. In some ways, we're giving the patient a brand new ear canal. With skin, we're going to be careful. It's a bit more delicate. Sometimes the skin can be really, really strongly adhered. You'll notice that in particularly the left ear, there was a bit more of a struggle to remove the skin. And with skin, we always run the risk of the skin clarinetting. Clarinetting is when you're suctioning dead skin, the skin can violently vibrate and flap against the tip of the sucker, and that emits a very loud, high-frequency squeal. And that's not only deafening for the patient, but it can also be deafening for the ear care practitioner. And at that stage, you should always try and stop. Sometimes you can manage the clarinetting by putting a bit of drops in, or just embedding the sucker a bit more into the skin so it doesn't have an opportunity to flap. And so we'll just detach this skin from the front part of the ear canal and the floor, the base of the ear canal. I've just got some forceps, so I can get the jaws of the forceps either side now. And I'm just going back in. You can see he's got some skin on the back part of the ear canal here. And I've got a good suction grip. I just went forwards towards the eardrum. In terms of the hearing, the symptoms are already alleviated because the blockage is gone, but the skin, because of their condition, it's not going to shed by itself. So I just want to remove as much as I can as safely as possible. It's not possible to, of course, remove every little last single flake of skin. Will be there all night, and that will be very uncomfortable for the patient. So we're just looking to tear away the big pieces. Now, this is a blind spot near the ear canal. I also mentioned it in yesterday's videos, but as you enter the ear, in the case of the right side, to the left, there's a little blind spot. And you can often get a bit of debris, wax, dead skin that's lodged and hidden away there. So we've just managed to get that out for the patient as well. You can just see all this dry, flaky skin. Eardrum's intact, looks healthy. And we're now going to tackle their left ear. So this ear, although it was blocked, they weren't experiencing any otalgia, any earache on this side. And straight away, I'm going for that blind spot. So that blind spot in the case of the left ear is to the right-hand side of the ear canal as you enter the ear. So you can see it's really strongly adhered, this skin. It's It's oxidized, it's been there for a while. So it's quite tough skin. I'm going to use some forceps in a minute to try and help detach this thickened skin. I'm just trying to get the bottom jaw underneath the skin. I don't want to make contact with the canal wall because we are approaching the bony portion and that can be uncomfortable. And I'm just trying to tear away. And I was hoping that as I got the forceps in and I got a good grip on it, that all this skin and the debris bit further in the ear will all come out together, but it never. So just to be a bit more patient. So I've just gone back in with the suction probe, and I'm on the front part of the ear canal here. This skin's quite tough, so actually, whilst I was doing that, some of the more medial dry skin came forwards with the sucker. You see there's a few hairs there matted. So see the patient's eardrum in the distance, even from this distance away from the eardrum, we can actually see the hammer bone and the incus, which is also known as the anvil. So that's the bone just to the right of the hammer bone. You can't always see it in patients. The younger the patient, the more likely you are to see it because the eardrum's more translucent, more transparent. And as we age, the eardrum can become a bit more opaque and less transparent. So you should always be able to see the hammer bone, the first bone, when we examine the ear. But the incus, the middle bone, not always. And again, just trying to you can see how close we are to the bottom of the ear canal with the jaw there. So need a really steady hand. I'm just trying to lift this up and away. And again, the forceps weren't very beneficial in this particular. Sometimes forceps works really, really well. It depends on the how the skin is, the consistency, the thickness, but it just wasn't as effective in this ear. So we've just gone back to the suction probe. Haven't got any clarinetting, so we're okay to continue. And again, when I first started removing wax many moons ago, I would probably have left this. And even if I did leave this now, it's not a massive detriment to the patient, because whenever we're trying to remove earwax, we're trying to really alleviate them of their symptoms. And in this case, it's to improve their hearing, stop the hearing aid whistling, feedbacking, and also the pain, the otalgia they're experiencing in the right ear. But as I've, over the years, as my skill levels have improved, I feel a lot more comfortable now doing a few more complex procedures and removing skin like this from the ear canal. There's just a bit on the back part of the ear canal here, just posteriorly. Well, I hope you enjoyed that video, guys, and you're keeping well and safe. And do take care of yourself. Remember, be nice and be kind. Bye.